had a treatment your doctor ordered denied? Not reviewed by a physician, not evaluated by a clinical expert, but denied by an algorithm. Have you ever waited weeks for a specialist appointment only to watch your doctor spend most of that visit typing into a computer instead of looking at you? Or maybe you're running a practice and your staff is spending hours every day fighting insurance companies over approvals that used to go through, not because the care changed, but because the payer deployed an AI to say no faster. AI is transforming healthcare, and that story has two very different sides. Today, we're going to look at both of them. I'm Heather Skousen, and this is Behind the Business of Healthcare. Today, we are cutting through the hype and into the real operational shifts underway in healthcare, what AI is improving, where it's being weaponized against the very people it should serve, and what all three of our audiences, patients, practice managers, and healthcare leaders, need to know. Let's start with context. AI is not new to healthcare. Algorithms have been quietly working in the background for decades, helping radiologists read scans, flagging drug interactions, and powering billing engines. What's different today is the sophistication. Large language models and machine learning tools can now read, reason about, and act on clinical and administrative data in ways that weren't possible just a few years ago. That capability cuts in two directions. And this is the part that the tech press doesn't always tell you. On one hand, AI is being used by providers and health systems to reduce administrative burden, improve access, and give clinicians more time for patient care. These are real gains with real evidence behind them. On the other hand, AI is being used by insurance companies, payers, to deny claims faster, override clinical decisions with algorithms, and systematically reduce payouts. And that is not just speculation. It is the subject of congressional investigations, federal lawsuits, and some of the most important healthcare policy debates happening right now. The same technology that can free a doctor from paperwork can also be used to deny a patient the care their doctor ordered. Which outcome you get depends entirely on who's deploying the AI and why. We are going to cover both today. Every segment on what AI can do for healthcare operations also comes with an honest look at where it's being misused, because you deserve the full picture. Scheduling is one of the most universally painful points in healthcare. Whether you're the patient trying to get seen, the front desk staff managing a full schedule, or the administrator watching utilization numbers bleed, AI driven scheduling tools are honestly improving this process in most healthcare organizations that have deployed them. What effective AI scheduling does? Analyzes no show history and intelligently manages overbooking so fewer slots go to waste. Sends proactive outreach via text or app to fill last minute cancellations in real time, matches patient care needs to the right provider type and the visit length, identifies patients overdue for follow up care before they fall through the cracks, optimizes OR and procedure block scheduling based on predicted case duration. For patients, AI scheduling should mean shorter waits, smarter reminders, and a system that actively works to keep you connected to your care. If your provider uses AI scheduling, you may receive more personalized outreach. If you feel you are being systematically scheduled at less convenient times or for shorter visits than your condition requires, that is worth raising with your care team directly. For practice managers and leaders, early adopters report 10 to 20% reductions in no show rates and meaningful access score improvements. An unfilled slot costs $150 to $200 in lost revenue. At scale, AI scheduling is a clear return on investment play, but make sure your vendor's optimization targets include patient access and equity, not just utilization rates. Algorithms optimizing purely for throughput can inadvertently disadvantage complex patients who need more time. The critical concern here: watch for scheduling AI that is optimized to reduce visit length or steer patients towards lower cost visit types without clinical justification. AI can be configured to serve operational efficiencies at the expense of a patient need. The parameters that drive the algorithm matter enormously. Here is a number that should bother everyone in this conversation. Physicians spend, on average, nearly 2 hours of administrative work for every 1 hour of direct patient care. Some research even puts EHR documentation burden at 4 to 6 hours per day. That is a doctor spending half of their working day typing, not treating. Ambient AI scribes are one of the most promising and patient positive applications of AI in clinical settings. They listen, with your consent, to a doctor patient conversation, transcribe the encounter, generate a structured clinical note, and present it to the physician to review and sign. That's it. The doctor stops typing. The visit becomes a conversation again. For a list of leading AI scribe tools currently in use, check the video description and see the comments below. Physicians using these tools report saving 60 to 90 minutes per day on documentation. Early patient studies show people feel more heard in AI scribed visits because the doctor is looking at them, not a screen. For patients, you have the right to know when an AI scribe is being used during your visit and the right to decline. AI scribe tools are designed to help your doctor pay more attention to you, not less. If you are ever uncertain, ask your doctor directly. Is an AI tool listening to or recording our conversation? And what happens to that recording? For practice managers and leaders, AI scribes offer some of the fastest return on investment through physician retention, reduced burnout, and improved documentation quality that supports better coding accuracy. But critical governance requirements need to be set up. Establish clear review and attestation policies. Ensure patient consent is obtained and documented, and build regular AI output auditing into your quality program. The goal of ambient AI scribing is not to automate the doctor, it is to give the doctor back the time to be a doctor and the presence to be a human. Prior authorization may be the single topic in healthcare where AI is playing the most dramatically contradictory roles at the same time. Providers are using AI to fight the prior auth process, payers are using AI to accelerate and expand it, and patients are caught in the middle. Let's start with the provider side, and then we're going to get into what payers are doing because that is the part that most people are not talking enough about. The AMA reports physicians complete an average of 45 prior authorizations per week, and 94% say that the process has at least some negative impact on patient care. What provider side AI is doing to fight prior auth? Auto identifying which orders require authorization before the order is placed, eliminating surprise delays. Pre populating auth requests with clinical documentation pulled directly from the EHR. Predicting approval likelihood based on payer history so staff can intervene early. Submitting requests electronically and tracking status without manual follow up. Auto generating appeal documentation when denials arrive. That is the good news. Health systems implementing these tools report a 50 to 70% reduction in staff time spent on prior authorization. That is real time saved. Faster approvals, less friction, quicker access to care. Now, here is the other side of this story. Multiple major insurance companies, including United Healthcare and Cigna, have faced congressional scrutiny, federal investigations, and class action lawsuits for deploying AI algorithms that deny prior authorization requests at dramatically higher rates than human reviewers did. In some reported cases, AI denial rates were running 10 times higher than the same payer's human reviewers. In at least one high profile case, an algorithm was found to be overriding physician recommendations with a denial rate of over 90%, with individual reviewers spending an average of just seconds per case. Let's be precise about what's happening here. These are not AI tools making nuanced clinical determinations. These are denial optimization algorithms configured to say no faster, at scale, with minimal human oversight. The clinical justification is often a fig leaf. For patients, if you receive a prior authorization denial, you have rights. You should exercise them. You have the right to request a peer to peer review between your physician and a clinician at the insurance company. You have the right to file a formal appeal. You have the right to request an expedited review if your condition is urgent. If you're on Medicare Advantage, you have the right to request an independent review. Do not accept an algorithm's denial as the final word, especially for treatments your physician believes you are medically necessary. Ask your provider's office to help you escalate. For practice managers and leaders, this is a two front battle. Your AI tool should be helping your staff fight back against payer denials, automating appeals, tracking denial patterns, and identifying payers with inflated denial rates so that you can escalate those relationships. Document everything. Denial pattern data is your best leverage in payer contract negotiations and increasingly in regulatory complaints. Revenue cycle AI, like prior authorization AI, has two very different stories depending on which side of the transaction you're on. For providers using AI to clean up their own claim process, the results are real. AI claim scrubbing reduces submission errors. Intelligent denial triage focuses staff effort where it matters most. Pattern recognition surfaces systemic billing issues before they compound. Health systems report denial rate reductions of 20 to 40% and faster days in accounts receivable. On the provider side, AI in claim cycle, there are pre submission claim scrubbing, catching coding errors, missing modifiers, eligibility mismatches before claims go out, real time verification of patient eligibility and benefit coverage before the visit, post denial triage, ranking denied claims by dollar value and appeal likelihood, auto generated appeal letters with supporting clinical documentation, pattern recognition, surfacing systemic denial trends by payer, service line, or coder. All of that is legitimate and honestly useful. But now let's talk about how payers are using AI on their side of the claims equation, because this is where serious harm is occurring. Insurance companies are deploying AI powered claims review systems that are systematically denying or downcoding claims that human reviewers would have approved. In documented cases, AI review tools have flagged claims for denial based on statistical patterns, not individual clinical review. Some systems have been configured to automatically deny claims that fall outside a statistically modeled expected range, regardless of the clinical facts of that specific patient's case. Patients end up with larger bills, providers eat the loss or spend resources on appeals, and the algorithm profits. There is a difference between AI that makes claims processing more accurate and AI that makes claims processing more profitable for the payer at the expense of the patient. The technology is the same, the intent is not. AI powered workflow analysis is one of the less glamorous but high value applications in healthcare operations. And unlike prior author claims, it is a tool primarily deployed by providers to improve their own processes, which keeps the incentive structure more aligned. Healthcare organizations are extraordinarily complex. Patient intake triage, bed management, discharge planning, medication administration, supply chain, staffing, all running simultaneously, all independent. Most organizations have only a rough sense of where their real bottlenecks are. AI can change that. So, what AI workforce analysis can surface? Where care delays consistently occur, and which step is actually causing them. Unnecessary handoffs or redundant data entry that add time with no clinical value. Staffing mismatches, too many people on one task and too few on another. Compliance gaps, required steps in a process that are routinely skipped. Variations between clinicians, units, and locations handling the same process differently. For patients, workflow AI helps hospitals find and fix hidden delays that affect your care. How long you wait for a bed, how quickly your discharge paperwork is ready, how fast your lab results reach your care team. When institutions understand their own operations better, patients spend less time waiting for things to happen. For practice managers and leaders, specialized healthcare vendors are bringing process mining to health systems. Some combine workflow analytics with robotic process automation, using AI to identify a bottleneck and then deploying automation to handle the repetitive task. This is a lean methodology powered by machine intelligence. Ensure your implementation includes frontline staff voices. The people closest to the work often know exactly where the bottlenecks are, and their buy in is essential to sustainable change. Organizations that understand their workflows at granular detail will be better positioned to scale care, manage staffing pressures, and improve quality and cost at the same time. Let's talk about the workforce because this question lives at the intersection of everything we have discussed today. When AI is deployed well, it reshapes jobs in ways that benefit the people in them. When it's deployed poorly or weaponized by payers, it eliminates the human judgment that was protecting patients. Healthcare is chronically understaffed across nearly every role. AI is far more likely to reshape jobs than eliminate them in the near term, but some roles will change significantly. Medical coders. AI is already capable of reading clinical documentation and suggesting codes. As ambient scribing and AI coding tools mature together, primary coding will shift towards auditing AI output, handling complex cases, and managing appeals, requiring more judgment, not less. Prior authorization specialists. As AI automates routine auth submissions, these roles shift towards managing payer escalations and peer to peer reviews. But here's the flip side. As payers use AI to deny more claims, the volume of appeal and escalation work is actually growing, which means this role may not shrink as fast as some predict. Patient access representatives and schedulers. AI handles routine intake and eligibility. Human staff shift towards complex cases, patient advocacy, and exception management, the situations where human judgment and empathy are irreplaceable. Revenue cycle staff. AI reduces routine rework volume, but as payer denial rates climb due to denial tools, the volume of appeal and recovery work is increasing, not decreasing. Revenue cycle staff who understand AI outputs and payer denial patterns will be more valuable than ever. Radiologists and diagnostic specialties. FDA cleared AI diagnostic tools are increasing. The role evolves towards AI supervision, complex interpretation, and high value consultation work. Roles that are growing. On the flip side, AI is also creating new categories of work. Healthcare organizations are going to need people who can implement these tools, monitor their outputs, audit their accuracy, and govern their use, roles that barely existed 5 years ago. These are not niche positions anymore. They are becoming core to how healthcare systems operate. For patients, AI changing healthcare jobs is not simply a story of automation and replacing workers. In many cases, especially given the rising payer AI denial rates, the demand for skilled human advocates, billers, and navigators who can fight back against the algorithmic decisions is actually increasing. The human who understands how AI denials works is the human best positioned to overturn them. For practice managers and leaders, the organizations that win the AI transition will invest in upskilling their existing workforce, not cutting it. Staff who understand AI outputs are more effective, more engaged, and more likely to stay. And in the current environment, staff who can analyze payer denial patterns and build effective appeal strategies are among your most valuable revenue cycle assets. The workforce of the future in healthcare is not human versus AI, it's humans working with AI and in some cases, humans protecting patients from AI. Burnout connects everything we have talked about today, and it has two very different relationships with AI, one that offers genuine hope and one that is making the problem worse. Healthcare is in a workforce crisis. Nursing shortages, physician attrition, administrative staff turnover running as high as 40% annually in some systems. Over 50% of physicians report symptoms of burnout, and the number one driver is not clinical complexity, it's administrative burden. The thing burning out our clinical workforce is not the clinical work, it's the paperwork, the clicks, the prior authorizations, the denials, the documentation, the inbox. And AI is on both sides of that equation. Where provider AI reduces burnout, AI scribes cut documentation time by 60 to 90 minutes per day, giving clinicians their evenings back. Automated prior authorizations reduces one of the most frustrating daily friction points in practice. Intelligent scheduling gives staff more predictable, balanced workdays. Workflow AI surfaces inefficiencies that create team stress and communication breakdowns. There is a real human story here. A nurse practitioner who spends two fewer hours on documentation has more time with patients and more energy when they get home. A physician who stops doing prior authorizations at 9 at night is less likely to leave medicine. Where payer AI is making burnout worse, every AI generated denial that requires a peer to peer review is an hour of a physician's time, often unpaid. Every appeal that requires clinical documentation assembly is time a care team spends on paperwork, not patients. The psychological toll of fighting an algorithm that will never acknowledge clinical nuance is real and documented. Practices that cannot afford AI appeal tools are being systematically outgunned by payer AI, compounding administrative burden for already stretched staff. Payer AI is not reducing administrative burden for providers, it's increasing it. When an insurer deploys AI to deny faster, the administrative response required from the clinical side scales with it. The burnout crisis cannot be fully addressed on the provider side alone as long as payers are using AI to generate more work, not less. For patients, your care team's administrative burden directly affects the quality of care you receive. Burned out providers have shorter visits, make more errors, and are more likely to leave a practice, taking their expertise and your relationship with them. When you hear that a doctor is leaving a practice because of insurance reasons, payer AI is often part of that story. For practice managers and leaders, the business case for addressing burnout is clear. $4.6 billion annually in turnover, reduced productivity, and increased error rates. Deploying provider side AI to reduce administrative burden is one lever. The other lever is collective advocacy against payer AI practices that are generating new administrative burden as fast as providers can eliminate the old one. Both matter. If AI is deployed thoughtfully on the provider side and regulated appropriately on the payer side, it has real potential to make healthcare more sustainable for the people who deliver it and more humane for the people who receive it. That second condition is not optional. Let me bring this together. AI in healthcare is not a simple good news story. It's a technology being adopted simultaneously by organizations with very different missions and incentive structures, and the outcomes are as different as those missions. The AI that helps your doctor spend more time with you is real. The AI that denies your claim without a human reviewing your case is also real. Both deserve your attention, and both require a response. If you are a patient, know your rights. When you receive a denial, whether it's for prior authorization or a claim, ask whether AI or an automated system was involved. Request a peer to peer review. File an appeal. Contact your state insurance commissioner if you believe a denial was inappropriate. AI driven denials are overturned at high rates when a human actually looks at the case. And ask your care team which AI tools they use, how your data is handled, and how you can either consent or opt out. If you are a practice manager or administrator, fight on both fronts. Deploy provider side AI where it reduces burden, scribing, scheduling, workflow analysis, claim scrubbing, and track your payer denial rates with rigor. If a payer's denial rate has risen sharply, document it. Use it in contract negotiations. Report it to your provider association. The aggregate data is your leverage. Individual practices cannot win this fight. Organized, data driven advocacy can. If you are a healthcare leader, build governance before you build deployment. Every AI tool you deploy needs an owner, a review process, and a defined response when it's wrong. Build an equity lens into your evaluation. AI trained on biased data produces biased outcomes. Invest in your workforce, not just your software, and take a position on payer AI. Health system leaders have the platform and the data to shape this regulatory conversation in ways that individual providers cannot. Use it. AI is not going to save healthcare by itself, but it's also not going to destroy it either. It is going to amplify whatever the people deploying it intend, whether that is for better care or better profits at the expense of care. The patients, providers, and leaders who understand both sides of this story will be the ones best positioned to shape what comes next. That is why conversations like this matter. Thank you for watching Behind the Business of Healthcare. If this gave you something useful, subscribe. Share it with someone who needs to hear both sides of the AI story. And leave a comment. I want to know, has payer AI affected your practice or your care? Let's talk about it. See you next time.